Hi, good afternoon. So right now I'm gonna report my case study. So presented by myself, Anthony Ian Dangoy. So my case study is all about patient information was age 70 years old with a height of 5'10", and then weight generally 200 pounds, and then it was admitted on date January 24, 2020 with a cold status of. So this patient has any information all about the respiratory history such as COPD, as the patient was diagnosed already previously and was diagnosed as severe. And then he has a smoking history of previously smoker of 1 to 2 packs per day and officially quit smoking on 2012. And then he has also a medical history of hypertension, diabetes, and pancreatitis. And so patient information is that the patient first was being admitted in a rural hospital and first complained of chills upon admission and transferred to another hospital for respiratory failure. And then due to his COPD, the patient was intubated in 2012 as he was having also respiratory failure. And then prior to that, the patient was also on home oxygen using 3 liters via auto concentrator, and he also has a maintenance medication of home nebulization bronchodilators to prevent any exacerbations. And then the patient has a physical exam as what I've assessed to be obese, generally with 200 pounds, and is somnolent. He has also a neck size which is large, supple without mass, and then the patient also has a 10-foot dyspnea, especially if he would try to do any exertional movements or mild movements. And then the patient's occupation, he previously worked as a laborer. So the chief complaint of this patient has shortness of breath and chills. And then the diagnosis was COPD, emphysema, and diabetes. So general appearance with this patient is that the patient's color was normal. He has a temperature of 96 Fahrenheit, sensorium alert, accessory muscle use. Though he is COPD, he does not show any distress or any diaphoretic. He also have a normal, regular breathing pattern. No any retractions present with a equal or symmetrical chest expansion with no edemas. So the vital signs upon my assessment is he has a heart rate of 77 with respirations of 18, SpO2 92, which is acceptable for COPD patients, and then with a FiO2 using an oxygen 3 liters with a blood pressure of 124 to over 67. And then he has also an intake urine, also outtake output of 3960 intake and 2080 for the output. And then the breath sounds upon my assessment is he has no wheezes, rheos, or rhonchi, but I also noticed that he has a diminished breath sounds, specifically in the lower lobe. And then also with his breath sounds, I've noticed the patient to have a prolonged exhalation time, which is pretty evident for that kind of a patient, as that patient, due to his COPD, it would lead to air trapping and also due to its constriction. So my other assessments is that the patient showed any heart regular rate and rhythm, and then also the patient showed no any edema, peripheral edema, none. Patient seen not cyanotic. And then the breath sounds, as what I've mentioned earlier, it does indicate a prolonged exhalation bilaterally with a diminished breath sounds on the lower lobe. And then the connections that I can made for this patient is these breath sounds, because on the lower lobe, because of its diminished breath sound, it may also suggest any consolidation And then also the patient also has a non-productive cough right after treatments. When I instruct the patient, he couldn't expel anything. And then while he attempt to cough, the patient also, I've noticed a wheeze sound inside the airway. So that would also due to its constriction and because of its COPD case. And then the patient also has a frequent dyspnea. Even mild activities such as minor movement in his patient bed in the bed, he would complain any shortness of breath. And then with that, despite him having shortness of breath, he still didn't experience any retractions or distress. He also didn't have a SpO2 level of less than 90%. So other things, clinical proof for this patient is that the patient's chest X-ray. So with the patient's chest X-ray, I can tell why is it clinical proof is because it showed a enlargement of the heart or cardiomegaly with increased bilateral thickening secondary to interstitial pulmonary edema. And also another thing with the patient's chest X-ray, I've noticed the patient's X-ray to be having a hyperinflation and also have increased volume with increased peripheral markings and also has a depressed diaphragm, which is pretty normal, or shall we say, which is pretty obvious for those patients who are COPD. And then another thing is with the patient's arterial blood gas. So the reason why I can say that it's another clinical proof because as previously noted, the patient was having a respiratory failure before. So being respiratory failure, it might also lead to having a ventilatory failure where it showed with this result to have an ABG of a chronic respiratory acidosis. So with the ABG, it might also lead because the bicarb is trying to compensate with its abnormality of the patient's CO2 level and also its glucose. So as what I mentioned before, the patient was having diabetes, so he has an increase in value. So definitely with increase in glucose, it will also affect the patient's lungs if not being corrected because it will lead to any inflammation and also decrease lung function. So for example, if the patient's condition was not being corrected in terms of his glucose, it will lead to any comorbidities such as in his lungs or any other areas of his body, such as it will lead to cardiovascular disease. It will also lead to heart failure, obstructive sleep apnea, and also worse, lung cancer. So moving on, the labs that I have here is he has a white blood cells of 11.9, RBC of 3.22, hemoglobin of 9.4, hematocrit of 31.9 with a platelets of 335. Coagulation INR is less than 1.0. Chemistry labs has a glucose of 186, which is very high, albumin of 2.7, BUN of 40, creatinine 1.4, and sodium 144, and potassium 4.7, chloride 115. So this one indicates the WBC to have increased due to infection, and also RBC, hemoglobin, and hematocrit, they would always come all together and it will correlate because it definitely means due to its decrease in values, it meaning there is a decreased O2 circulation in the body, as evidently noted the patient to have a hypoxemia and also have a severe respiratory acidosis. And then the glucose is increased, albumin is 2.7, BUN is 40, increased, creatinine is increased. So this is the arterial blood gas. So as what we noticed, the PO2 is 61, which is mild hypoxemia, as what interpreted chronic respiratory acidosis with mild hypoxemia. So that was evidently noted to the patient's laboratory in hemoglobin, hematocrit, and RBC due to its decreased O2 circulation in the body. So one of the recommended treatments that I can give is to prevent any exacerbations. Initially, for COPD patients, we would always put them on BiPAP or non-invasive positive pressure ventilation. So one of the reasons why we put it first on BiPAP instead of invasive is we want to prevent the patient to have any muscle atrophy, as if the patient does have any muscle atrophy, it would also prevent any success in terms of weaning. And also bronchodilators, such as long-acting. So the reason why I would recommend to have bronchodilators is to prevent exacerbations and also for maintenance, as it is one of the effective treatments in terms of the COPD patients. So moving on, MD interpretation. This was the X-ray was taken on January 24. Patient has, as what indicated, bronchial wall thickening, and there are a few linear markings in the left lung base suggesting left basilar atelectatic inflammatory change. Is the chest X-ray improving? No, because it was also being noted to have enlargement of the heart or cardiomegaly with an increased bilateral interstitial thickening, which is secondary to pulmonary edema. There was also an abnormal thickening of the bronchial walls, as what I previously mentioned, to have an increase in interstitial markings, and also they also have a depressed diaphragm. What connections can be made with this chest X-ray? As what I mentioned, it's the depressed diaphragm because it will cause an air trapping as evident by my assessments during its breath sounds, as the patient has a prolonged exhalation time. And then medications and therapies, non-respiratory medications, these are the meds the patient was being given, such as aspirin for heart attack, stroke, Benadryl for fever, upper respiratory allergies, Lipitor for the heart, such as a stroke, and also for diabetes, Plavix for thrombolytic prevention, and for acute coronary syndrome, Cozar for hypertension, diabetes, and vancomycin for bacterial. For the respiratory medications, is the patient has Dulera, which is indicated for maintenance medication for COPD, and also DUNAB treatment for the COPD, and Cibri Neohaler for also for its COPD treatment. So for the Dulera and Cibri, it will be given twice a day, BID, and DUNAB. So moving on, one of the things that I can suggest to this patient is to have BiPAP at home if the patient would persist to any signs of hypoxemia, such as any distress diaphoretic or cyanosis. So just recommend it to the patient, or if not, we can also give them a home oxygen, maybe about 2 to 3 liters. We don't give them too much oxygen because it would also lead to too much carbon dioxide, especially we don't allow that to COPD patients. And then we can also recommend to the patient by being admitted to pulmonary rehab in order for them to build their strength, or shall we say, we can also give them appropriate therapy such as a 6-minute walk test to check their endurance. And then we also have to let them avoid from any extreme hot and cold temperatures at home. Make sure that they are being cessated from any exposures of cigarette smoking or second-hand or third-hand smoke. And then let them eat healthy diet such as fruits and vegetables, and limit intake of sugary foods, so that way the patient's glucose would be back to normal. And then long-acting medications in order to improve the dyspnea health status, and also it would reduce any frequent hospitalizations. And then we can also try to recommend them practice to do per-sleep breathing to improve its ventilation and oxygenation. So expected outcomes, short term is there will be improvement of breath sounds, improved lung function, reduced barrel chest appearance, and then reduced mood swings such as anxiety or sometimes depression, improvement of symptoms such as resting dyspnea or exertional dyspnea, uh, improvement of their auto-saturation, and then their confusion and drowsiness. And then reduced onset of physical signs such as cyanosis, peripheral edema, or some jugular vein distension. Long term is patient would be hemodynamically stable, non-manifested diabetes, decreased admission in the hospital, uh, PRN use of inhaler medications, return to their normal daily activities, improve PFT results. This the patient would show obstructive result, but it doesn't mean that the PFT results of this patient would be pretty back to normal. It would still indicate obstructive result, but it significantly improved quite a bit compared to the previous PFT results. Patient presentation is the patient has an underweight appearance, accessory muscle use, retractions, wheezing, diminished breath sounds, finger clubbing, chest x-ray, translucent depressed diaphragm, altered sensorium, and then the actual presentation, patient is obese, patient didn't show any signs of distress, usage of accessory muscles, though the patient did exhibit to have shortness of breath. And then the patient appeared diminished under breath sounds, mostly in the lower lobes, and then with a prolonged exhalation time due to air trapping. And then the patient doesn't have any edema, and then bronchial wall thickening with a cardiomegaly with in terms of their chest x-ray. And then the patient appear fine. They're not comatose, and then it was able to follow any specific instruction. So these are my resources. I took it from the Clinical Manifestations book, Gold COPD, and also from Egan's. I think that's all, and thank you.